a Senior Program Officer at the Center for Healthcare Strategies and the Center's Project Coordinator for the CHIPRA CME Collaborative. The Center works with states, Medicaid agencies, and health plans and others to improve health quality and reduce disparities for low-income families and individuals with chronic illnesses and disabilities. In keeping with that mission and the priorities you see on the current slide, in 2009, CHCS sought out a partnership with a number of states to apply for one of 10 demonstration grants to improve the quality of care for children enrolled in Medicaid and the Children's Health Insurance Program, or CHIP. In February 2010, Maryland, in partnership with Georgia and Wyoming, was awarded a CHIPRA Quality Demonstration Grant by the Centers for Medicare and Medicaid. The states in the CHIPRA Collaborative share the common goals of improving clinical and functional outcomes, cost outcomes, access to home and community-based services, and family and youth resiliency for children and youth with severe behavioral health needs, and are working to accomplish this by implementing or expanding a care management entity model. Our webinar this afternoon will describe building bridges, both as a national initiative and from the perspective of a provider in Massachusetts, and will highlight the experience of New Jersey and one of its residential treatment providers in changing its philosophy and service delivery model to work more collaboratively with children and families served by CMEs. We're pleased to have as presenters Dr. Christopher Balanci, Assistant Professor at Tufts University School of Medicine Department of Psychiatry and Senior Psychiatric Consultant at Walker in Needham, Massachusetts. Walker is a multi-service agency that works with children experiencing severe emotional and behavioral disorders secondary to major mental illness, trauma, and developmental disorders. Dr. Balanci is also President-elect of the American Association of Children's Residential Centers. We're also joined by Brian Hancock, Deputy Director of Operations at Robin's Nest, a private nonprofit children's services organization that serves youth and their families through a wide array of community-based residential and in-home services. Some of you may be familiar with Brian in his former role as Deputy Division Director for the Division of Child Behavioral Health Services for the state of New Jersey, the Department of Children and Families. And Brian is joined in his presentation this afternoon by Roy Lightstein, Executive Director of the Children's Home of Burlington County, a nonprofit organization that provides special education, residential, and emergency shelter services in 2 counties in New Jersey. Sheila Pyries, our Senior Consultant for Child Health Quality at CHCS, will start us off this afternoon with a brief introduction of the topic.
Thanks, Diana, and I will be very brief. The care management entity model that our states are implementing is built on system of care and high-quality wraparound values and principles. And the outcomes that they're trying to achieve, particularly access to home and community-based services and reduction in per capita cost of children served, have implications for residential providers. And we're lucky to have presenters on the panel today who can address a number of things, such as the implications for changing programming within residential centers to reflect system of care values, partnerships with families and youth, individualized care, strength-based approach, solution-focused services and supports, connection to community-based care management entity, child and family teams or wraparound teams, reducing admissions and lengths of stay and potentially bed need, and customizing programming for youth that may have particularly complex behavioral health challenges. So just setting that context, I will turn it over to Chris Balanci, who's going to begin with the national perspective and his work in Massachusetts. Chris?
Thank you, Sheila and Diana. Thank you for the first slide. I am a child and adolescent psychiatrist, and I've been at Walker for about 16 years. And during that time, I've seen a lot of change. Probably the most significant policy shifts that I've seen over the course of my time working in residential treatment has come in the last decade. And as part of my work on the Child Welfare League of America's Mental Health Advisory Board and my involvement with the American Association of Children's Residential Centers, I became aware of an initiative called the Building Bridges Initiative that came out of SAMHSA's Child and Family branch led by Gary Blau. And Gary had been coming to AACRC meetings for a number of years and really challenging us as providers to think about reforming the way we serve children and families. And he was hearing a lot from family advocates about how residential treatment wasn't really working collaboratively with families and community providers. There was a reputation of residential treatment as taking kids as long as possible and then kind of serving them up, but not in a way that integrated the care into the community, had appropriate aftercare supports, and appropriately engaged the family's strengths. Often families felt very isolated. And there was almost this notion, I haven't quite developed the slide yet to graphically depict it, but where there's this little traffic circle and the parents come in and or child welfare in many cases, come in and drop off the child, and there's a little conveyor belt going into this old-fashioned factory-looking building with smoke coming out the top. And then after a year or 18 months, the family or the agency gets a call that the child is ready to be picked up, and out comes the back of the factory with little angel wings on the child's back as a graphic description of the way this work was supposed to be happening, or in many cases, sadly, I think was happening. And so Gary actually took some risk in inviting a number of national residential advocacy groups, including the American Association of Children's Residential Centers, the Child Welfare League, National Association of Children's Behavioral Health, as well as advocate organizations like the Casey Family Organization, the Federation for Families. There were youth advocates, and there were all told, about 200 of us that went to Omaha, Nebraska for the first Building Bridges initiative, which occurred about 6 years ago. And his goals at the time were really to challenge some of the siloed thinking that had occurred historically between residential treatment and community-based care providers and advocates of community-based care. And it was a very interesting couple of days that we spent together. I think there was a lot of consciousness raising and a lot of learning, and instead of talking past one another, which I think had been the historical precedent, we actually were forced to talk to each other. And we were able to come out of that process with what I believe is a very strong resolution and set of beliefs and values that did include the role of residential treatment in a system of care and a system array supporting children with complex mental health, behavioral health, emotional health needs. So I felt very good about that process. We've now had 3 Building Bridges summits, and there's been a whole slew of work that's been done in support of that initial joint resolution that came out of the first meeting. And I'll give you a reference to find some of the resources and supports around that. So if I could have the first slide. So the vision of Building Bridges really goes back to this initial description where there were community and residentially based treatment and service providers will have a shared responsibility with the family, with community-based support and community-based care providers to ensure that comprehensive mental health services and supports are available to improve the lives of young people and their families. And what I'm going to hope to do today in my talk is to describe a vision of a service delivery system that would be built from the ground up from the family and youth's perspective, rather than kind of the system's needs. The core values of Building Bridges, next slide, are very similar to CAST principles and system of care principles. So obviously a respect for cultural difference, family-driven and youth-guided treatment, preventing a need for custody relinquishment. That refers to the child welfare world, where after 18 months, in order for a child to continue to get funding for residential treatment, often the parents, even though there's no questions about abuse or neglect, have to surrender their child's custody and relinquish custody to the state in order for the funding to continue and for the state to get the federal match. Multi-service, holistic, comprehensive, and flexible. The goal should be for a decreased need for out-of-home care and integrate and coordinate with community providers. And I've always been very clear, even as president-elect of a child residential treatment advocacy organization, I think we would all love for the need for out-of-home care to go away. I do think that there will be an ongoing need, and I'm always happy to have the conversation about who those residential treatment providers should be serving, how long, and what that service should look like during the time that the child is in one of our treatment facilities. We should be utilizing relationship-based approaches. Next slide. In addition to those core system of care values that the resolution calls for, we went on to say we really strive for clinical excellence and quality standards, accessibility and community involvement, transition planning and services, both between settings and from the youth to adulthood, effective workforce development, and a core principle that there needs to be assessment, driving decision-making, evaluation, and continuous quality improvement. Next slide. Treatment and process should be driven by family and youth voice, where the family and the youth define success and they have choices. If the family is the customer, then they need to know what the product is that they're buying when they admit their child to the program. It was also a big desire on the part of families to get some choice in provider. Often these are such crisis-driven decisions, and the child ends up at the program directly from a hospital placement or a failed foster care placement, and the parents, when there are parents engaged in their child's care, often are bewildered and don't feel like they get appropriate say in which provider they choose. So families actually would love to see metrics that are being taken by the state about the provider in terms of their outcomes in order to be able to have a more informed decision when their child does need an out-of-home placement. We need to ask, what is it that you want to happen? What would make your life better? And I'm referring both to the child and the family. What are the outcomes that you're looking for? Next slide. There should be a desire, we should desire respect, or families desire respect and a central role in decision-making about what is essentially their lives and their treatment. One experiment that some providers are using is actually writing treatment plans jointly with the family. So it's not written by the professional and then just submitted to the parent for their signature, but actually sitting down with them in a much more collaborative process from the outset. There's a model here in IEPs, individual educational plans, where the process starts by asking the parents what is their vision for the child, and then very explicit benchmarks measuring outcomes to each individual goal throughout the IEP. I think we could do something similar in a care treatment plan. Parents and youth seek compassionate and respectful care. They also need continuity of services from the community to the residential, back to the community, and sometimes back to the residential. I've toyed with the notion that if you really were building a system that was family-driven, what families want is to not have to keep telling their story over and over to new and different providers every time they change which system they're working in or what level of care the child is getting served within. So often a child will have an outpatient team, and then if their behavior drives a crisis or something happens resulting in a hospitalization, they've got to tell the story over to a new inpatient team. Often the inpatient team doesn't talk to the outpatient team, and the family is often left trying to coordinate and communicate between those providers. Often this happens several times, so they go back to the outpatient provider. Meds may have been changed, diagnoses may have been changed by the inpatient team. The outpatient provider doesn't get the discharge summary for months after, doesn't know kind of why the meds were changed, but has to inherit the treatment plan as such. Child goes into crisis again, ends up hospitalized again, usually a different hospital, a whole new set of discussions, a whole new treatment plan, maybe other treatment recommendations or med changes, back to the outpatient provider, again with a lack of communication, ultimately land on a residential doorstep. Many of the kids that I've worked with at Walker will have had 3 or more psychiatric hospitalizations, And it's rare that anybody in the system can tell me why they're on the medicines that they're on, and often they're on 5 or more medicines at the same time, why they ended up having these repeated hospitalizations, what may have worked previously. You know, one of the things I always try to look for as a clinician is, was there a period where the child actually was doing well, and what sustained that growth and that progress? So families would love the same team to work with a child regardless of what level of care they're in. What would it look like if we did an assessment of the child and family strengths and needs and developed a team based on that assessment that could then work with the child regardless of what level of care they might need based on their level of acuity? For instance, the same team might work with that child whether they were on an inpatient setting, or if they were referred for residential treatment, the same team could work with that child in the residential setting and in the aftercare setting when they're back in the community. So bureaucratically, of course, it's a nightmare, but we are seeing some folks begin experimenting with at least core elements of that team being able to follow the family longitudinally, regardless of what level of care or system the child is having to reside in for safety reasons. They want help to recover and live successfully in the community. And I think residential providers would like that as well for their families. Next slide. Progress should be towards their value-derived outcomes, not some arbitrary values or goals that are set by clinicians. Youth and families need providers to listen, to accurately diagnose, and provide and link them with the right services and supports to get on with their lives. The further I get from training, the less reliable I find diagnoses, particularly with the youngest children that we serve. I'm always interested in what are the needs of this child, what are their strengths, and what are the barriers for their success? And then how do we go after those barriers, whether it involves teaching skills, working to remove obstacles, bringing in new supports and service providers, but ultimately, how do we end up instilling within this child and this family the strength that they need to be able to be successful? Families see residential's role primarily as crisis stabilization, and they want it to be a short-term intervention, not a place where children grow up, i.e. not an orphanage, but a treatment facility where skills can be taught and treatment can be jump-started, almost as a catalyst function in the growth of development for this family. Next slide. Many of the youth that were at the various Building Bridges meetings would talk about their own concerns about medication. Too many different types of medication being used without trying non-pharmacological interventions, such as evidence-based psychosocial interventions like cognitive behavioral therapy or dialectical behavioral therapy, and often medications being prescribed without an accurate diagnosis. At Walker, we were able to see children be discharged on 65% less medication from admission to discharge. And that's not because I was specifically targeting med reduction as a goal, but we would all do a multidisciplinary assessment. So I would look at the entire record, but I was fortunate to work with a couple of occupational therapists who would do careful analyses of past testing and current functioning of the child in terms of their fine and gross motor functioning and their sensory sensitivities. We had speech and language therapists that could very accurately pinpoint subtle social communication deficits that we see with some of our kids with Asperger's syndrome or autism spectrum disorders. We had excellent special educators that could fine-tune a reading disability or language-based learning disability and come up with substitutes and teach skills in order for the children to overcome those deficits. And then we would gather, having looked at past testing, having identified any new testing and done additional testing that was warranted. And we'd sit in a multidisciplinary way with the family, with the referring source, with the funder, and talk about what we each, from our disciplinary lens, thought might be going on for the child. And then we would ask, does that seem to be, did we get it right? Did we capture what you think makes sense? And my goal has always been to develop a biopsychosocial formulation so that the behavior makes sense in the context of this child's lived experience, as well as the strengths and needs that they bring to their situation. And in that context, we then were able to take kids off of medication in significant amounts, and sometimes even see them function much better, although most of the time we just didn't see them get any worse. It's very hard, I think, in the current climate in outpatient settings to feel comfortable removing medication. People just don't feel safe to do that. And so what happens is there's this accrual with each new treatment intervention. Each time the child gets hospitalized, another med is added, but nobody's taking them away. And the youth are very concerned about that. The other thing I always try to be careful to do is to talk with the youth about the rationale for the medication, and that the medication isn't controlling their behavior. They're still in charge of their bodies. Medicine is meant to help them to be able to utilize all of their strengths most efficiently and effectively. And that my hope is to only use the medicine for a short time while they still develop the skills needed to be able to function without that medicine. Of course, it depends on what the medicine's target symptoms are. The youth want to clearly understand what's expected of them in order for them to return home. It's rare that a youth isn't singularly focused on getting home. There are some youth who have had such horrific home life experiences that they're actually quite content to stay in the residential program, and those are some of the children I was most concerned about, frankly. Next slide. Families want daily communication or very frequent communication. Often you can develop a communication plan with families about what they want to be informed about and maybe what they don't want to be informed about. They appreciate written and verbal updates and reports. They want phone calls whenever there's something significant to report. They don't want to be surprised by what's going on. They want to feel like they've left their child in the hands of people that they can trust. And it takes a while for that trust to develop. They want flexible policies regarding visitation, and visits not having to be earned, but being considered an entitlement of the fact that this is a child that belongs in a family. At Walker, we instituted ID cards. So all the staff have ID cards, all the parents have ID cards, the same ID card essentially. We have a pretty open campus and a number of different buildings, and just as public schools have had to limit access through a single point of entry because of some of the school violence that's happened nationally, we have had to put key cards on each of our doors. But the parents have in their photo ID, they have access to the residential unit that their child is on. So they have 24-hour-a-day, 7-day-a-week access, and we encourage that. They're never unwelcome on our campus. We're not trying to hide anything from them, and we feel they're essential in the care and the treatment of their child. Parents also want education about the mental health issues impacting their family, at least from our perspective. And we often will invite parents to work alongside of our staff, either in the classroom or more commonly on the residential unit, so that we can learn what has been successful in the interventions the families have used with their children, but also so that we can actually do coaching of some of the skills and techniques that we're finding to be effective in working with their child. Families want to be connected with other families, both to give them hope, but to answer questions on a peer-to-peer level. And we were able to hire a parent liaison who was the parent of a child who had been in every level of care at Walker. So we have day treatment for kids that are living in the community and come to our therapeutic day school. We have residential treatment. We have acute treatment. So instead of going to hospital, children can come to our acute location. And this child had been in each of those settings. So the parent really knew our program quite well. She happened to also have a skill set that was great for us. She had been a executive director of a nonprofit human service agency, elder care agency. So she kind of got the world of nonprofit treatment milieus, and she's been great. And what I really found fascinating was the mere presence of a parent liaison, a parent advocate on staff. She would go to many of our clinical meetings, treatment team meetings, and her mere presence changed the dialogue. I found staff talking about families in a very different way. You know, I thought we had been pretty family-centered and family-driven, but the dialogue fundamentally changed the first day that Susan was able to be at some of those meetings. And it really makes a difference for the families as well. Provide other affected family members with the treatment services and supports they need. So not just looking at the identified patient of the child who happens to be in the residential treatment facility, but look at the whole family holistically. So we often will run sibling groups, because often the children of the impacted child, the child with the mental health needs, have significant issues, if not because of their own mental health issues, just having coped with some of the behaviors and the disruption that a child with mental health needs can cause to a family system. Teaching family strategies to help them manage their child's emotional and behavioral health needs. You're going to hear the same theme over: teaching, skills, coaching, connecting. These are the kind of verbs that we're talking about. We're not talking about curing. We're not talking about a power dynamic where the professionals are treating and the parents and child are receiving. It's much more of a dynamic, engaged process that the Building Bridges Initiative challenges us to endorse and move towards. Next slide. Families want the treatment plan linked between residential care and services and supports in the community so that there can be seamless aftercare. One of the things that I've always held as critically important is that we not develop an intervention that can't be replicated outside of the residential treatment center. Because how crazy is that? How are we helping anybody if it's what helps your child is only accessible when they're in a residential setting? We focus treatment on the skills needed to succeed at home in the community. So it's not good enough that they get better at the residential treatment center and we can extinguish the problematic behavior in that setting. They need to be doing well when they're back at home. So we often have been experimenting with partial residential so we can in a real way send the child out into the community, into the real life situations, and see whether or not the skills that they're working on developing in the residential treatment program are having legs outside of that program. I'm happy to say that about 3/4 of the children at Walker are able to transition to a less restrictive setting at point of discharge. And most of the ones that aren't still needed some treatment intervention but had aged out. We go up to about age 13. For adolescents, the focus should be on post-secondary education, job training, housing, and transportation needs in the aftercare setting. Not surprisingly, these are all areas that are clear predictors of long-term positive adult outcomes. So they need to be front and center, and we're thinking about what is it we're working on with our adolescents who are nearing transition age. Next slide. We need to provide someone for youth and families to contact after discharge. Many programs say, well, we can't muddy the clinical alliance with the next treater. And that's kind of a lot of hooey. I think we sometimes use clinical verbiage or clinical theories to get in the way of what really just makes common sense. I mean, if a child has been in a program for a year and has developed meaningful relationships with the treatment team, why will we abruptly stop those relationships just because the child is no longer in our treatment setting? We want to enhance resiliency. We want to promote growth and human development and connection. So why would we suddenly cut off that connection? Some states are even experimenting with warranting their services with residential treatment providers. In other words, if a child leaves and over the course of the next 6 or 12 months, they end up needing to come back into a residential setting, the provider takes them back free of charge. Parents also talked about not wanting their roles to be confused. So families don't want staff to act as surrogate parents or siblings. What they want is nurturing, affectionate, and committed staff, but not to step into what are appropriate parental and familial roles. Next slide. So now I'm going to be talking a little bit about how we transform practice. Those were some of the, what I've talked about thus far were some of the basic principles and some of the dialogue that I gleaned over the years with building bridges. So now I'm going to be talking about how residential treatment centers are responding to some of those challenges that Building Bridges has put forth and how one goes about transforming practice. So the first thing is to acknowledge that transformation is already taking place. It's important for people to see that there are folks who are able to do these things that may feel very difficult or frightening or undoable, when in fact there are many examples at this point of residential providers that have fundamentally retooled the way that they serve children and families, infused with the Building Bridges ideas. Next slide. Transformation is about rethinking what community-based services and supports need to be in place, both to reduce the reliance on residential services and to shape how the system as a whole will support community integration. So, residential treatment can't reform this system by itself. We need to have a network of supports and services in place. And in Massachusetts, we have this very interesting experiment called the Children's Behavioral Health Initiative, where through Medicaid, via a class action lawsuit, Medicaid is paying for therapeutic mentors for youth. So these are typically young adults who will take the youth into the community. It's almost kind of Big Brother plus, supporting specific clinical outcomes. There's in-home therapy being provided by Medicaid-funded clinicians. There are parent partners who work alongside of the parents in navigating systems. There are intensive care coordinators, ICCs, who help advocate for the service needs of the child and family, including that with the educational system. There's mobile crisis teams that can come to the house or the school with a goal of preventing rehospitalization. There's even ABA, Applied Behavioral Analysis, trained clinicians who can do consultation and treatment in the home, all being funded by Medicaid. Those kinds of service supports should ideally lead to less dependence on residential treatment over time. And then the trick is making sure that the residential providers are working collaboratively with some of those community-based service providers. And I just want to put in a note, Walker actually provides 2 of those 5 CBHI services. So the notion that residential treatment is divorced from community treatment is increasingly not the case. Most, if not, I'd say at least most of the agencies that I know through AACRC provide significant amounts of community-based care. So within the, Walker used to be called the Walker Home and School, and I've had to correct myself because it really is now a multi-service agency, from hospital level of care, residential treatment, day treatment, therapeutic after school, summer only programming, in-home therapy, a community mental health clinic, therapeutic mentors, in some cases using some of our own residential staff. So we really have a full service array within one agency at this point. And those are not rare examples. Next slide. Transformation depends on leadership and broad, sustained commitment. I can't emphasize this enough. And one of the conversations that came up early on in the Building Bridges dialogue was, how can states and policymakers help support this residential transformation and refitting that we're talking about? Ultimately, these programs have budgets, they have boards that look at bottom lines, and they need help with the business model to migrate away from a dependence on residential treatment, which is often the largest per diem funded service at these programs, to be able to develop more community-based care in a Medicaid-funded model where you're often billing at 15-minute increments. So what ways can states and policymakers engage productively with the executive team at a residential treatment center to support the kind of transformation that I'm describing? Some states have talked about programs being able to retain any cost savings in order to fund the transformative practices that we're describing. Next slide. Transformation goals and values derive from the voice and wisdom of youth and families, who ask that care be delivered in a manner that's respectful, engaging, empowering, normative, and flexible to meet the specific needs, desires, experiences, and culture of each family and youth. And I think I've been describing, how that system would look based on the family perspective rather than the system or funding perspective. Next slide. Transformation is done in partnership with families and youth. You know, the shift to family-driven and youth-guided care can be quite challenging, but it's really essentially quite rewarding. And I think most of us that have gone through this process feel like it's been some of the best work that we've ever been able to do, both in achieving outcomes but also feeling better at the end of the day. It's a lot more fun you're working alongside of people to shared goals and visions than working at odds with them, or feeling like they're resistant, which is often another clinical term that we use when people are doing what we want them to do. Achieving a genuine shift in power is not a small matter. I really want to emphasize that. And I'm not about to say that every agency is where we would like them to be in this regard. But I do think that most agencies are getting on board with the notion that this is where they need to take their programs. Next slide. Bias and perceptions held by staff and agency-employed family members, community members, and consumers must be addressed. You know, I always believe in speaking the truth in love. So, you know, as a clinician, I certainly have a perspective on what I think is going on, and I try to be sensitive when I'm at odds with the perspective that a family member might have about what's going on. And I think we just need to honestly agree sometimes to disagree and then decide how we're going to proceed from there. You know, it doesn't mean just accepting at face value what the family may be understanding as the origins of the child's behavioral issue or emotional disturbance. But it means being open also to the idea that the clinician isn't always right either. So I tend to talk in terms of a hypothesis. You know, after that multidisciplinary assessment where I've looked at what's going on with the child and the family and their strengths and needs and how I understand their behavior, I sit down with the family, usually even before the multidisciplinary team meeting, to share my particular impressions and get a sense as to whether or not that sounds right to them and what sounds wrong and what sounds right. I also share the write-up so that they can see and correct inaccuracies, which invariably there's many historical inaccuracies that get passed on from program to program, before we even sit down with the larger group, which I think is much more respectful of the parents, so that they're not having to correct inaccuracies in their own family history in front of the people who are paying for that service and what is often a large team. It's not uncommon that there's 15 or 20 people sitting around the table talking about this child and their family in front of their family and with their family. So an atmosphere of open communication needs to be fostered. And leadership needs to articulate clear expectations about how this principle will be operationalized. You know, families should be routinely asked for feedback, not simply, you know, via a satisfaction survey at the end of their residential stay. Next slide. I think owning the fact in the spirit of open communication that transformation can be scary and uncomfortable, both for the agency leadership, their boards, the staff, the communities, and the families themselves. You know, colleagues who have been through the process can provide valuable technical assistance and guidance. You need to be planful, and leadership needs to anticipate that there's going to be some pushback at times. Transformation ultimately requires change at all levels. So again, it's not just transformation of the residential system, and one of the things that we've really tried to emphasize at Building Bridges, even as we're developing outcomes measurement tools, it's not an outcome measurement tool just of the residential treatment provider. It's supposed to be the whole system, including the community care providers. So we need the help of national policy, state policy, community awareness and attitudes, local leadership, and planning processes. Workforce development, you know, so are the social work schools producing the clinicians of the future who are trained in evidence-based practice? One of the things that we've found quite confounding at Walker is that we're licensed by Department of Ed, Child Welfare, Mental Health, and Early Education and Development, kind of a foster home or preschool licensing body. And often the requirements of each of those agencies are at odds with one another. And so some of the flexibility that we would like to be able to have, we're hindered by the various regulations and bureaucratic hurdles that we have to jump through. So those are areas where we can work collaboratively together to try to instill support and remove barriers to the kind of progress we'd like to see and the transformation we'd like to see within our residential programs. Often there's a lack of external alignment that makes transformation difficult, and this is most commonly seen in the funding streams. Many of the most interesting transformation initiatives happening in residential treatment have required blending funding streams or braiding funding streams in ways that take some creativity and thinking outside of the box. Separately, you should have received, or I know that there was a posting of the fiscal strategies that came out of a recent work group by the Building Bridges group. And so I would refer to you to that document if you'd like to learn more about funding mechanisms. Next slide. And the next slide. Some critical infrastructure supports, including state-of-the-art supervision, is needed, mentoring, monitoring to the fidelity of whatever program you're using. Increasingly, residential providers are using evidence-based practices within their programs, and so a number of those evidence-based practices actually have their own fidelity measuring tool. Next slide. Transformation needs to be responsive to the community, so there's not a one-size-fits-all. So it really becomes important to instill a dialogue between the residential provider and the community that the residential provider is serving. Next slide. We need to embrace cultural diversity as an imperative strength. We're already a majority country under age 7. And in the next decade, that'll be true for almost all youth. So our ability to be bilingual and bicultural is going to be ever more important. And so how do you work with your provider agencies to instill that they share those values and are developing those cultural assets? Next slide. Transformation asks, does what we are doing make sense for children and their families? At its bedrock, that should be the question that organizes all of our systems of care. Because if it doesn't make sense for children and families, why are we doing it? So can you take a step back and look closely at the goals for each child and family, and then craft individualized responses based on that child and family's needs, not the needs of the system? Next slide. I talked about evidence-based practices. They should be used when appropriate after carefully considering the needs of each child. So individualizing the treatment intervention based on that child's specific treatment needs and clinical needs after an assessment has been done. Next slide. Transformation can be sustainable. It needs to be sustainable, but requires creativity, persistence, and ultimately data. The bottom line is that funding this new approach is challenging, but possible and sustainable. I will say it doesn't always save you money initially, but I do think it provides better care. Innovators have changed state Medicaid plans, braided funding streams, working differently with traditional daily rate structures, et cetera. And performance-based contracting is certainly a part of that as well. Next slide. This is the reference where you can find the fiscal strategies document at the buildingbridges4youth.org site. There's a number of resources that I will reference again in a few minutes that can be found at that website. So it's buildingbridges4youth.org. Next slide. Transformation requires sufficient capacity and effective community-based services in order to reduce unnecessary use of residential services, to provide strong ongoing community linkages, and to permit discharge in as short a time as possible. So, one of the most frustrating aspects is when we've had a child at Walker for a period of time and we feel like we've done the work that we set out to do, we've achieved the goals of the family and of the child and of the referring source, but the community system feels like the child is still too acutely ill, or their behaviors are such that they don't feel ready to take them back into the community. And so that's led a number of community providers or residential providers like Walker to actually get into the community provision business. There's a whole arm of Walker called Walker Partnerships which contracts often with public schools to help the transition of a child back into a public school community-based setting, and helping to adapt or develop strategies, and sometimes even staffing the child ourselves for a period of transition while the school gets used to the child being back in their community. It's not uncommon that we have to overcome some significant obstacles. You know, the children that we work with at Walker have often blazed some pretty horrific trails, and we have to undo some of that damage and the reputation that they bring back when they're going into the community setting again. Next slide. Transformation utilizes the child and family team and the wraparound process to plan and coordinate care regardless of the physical location of the child and with participation from all providers. That's kind of that model that I was describing earlier, where the child and family team is established early on when the issues are first identified by the family. A standardized assessment instrument and process is utilized to determine what is this family and child's strengths and needs. And then treatment planning is developed. But the service team, the clinical team that's wrapping around that child should be able to flexibly work with that child regardless of the setting that the child may need to be in based on the acuity of their presentation. This continuity affords all sorts of positives for the family, including a trusted home base, a virtual home base, if you will, to return to throughout their journeys. The child and family team will then tailor and customize the treatment and support plan regularly. You know, I believe as a scientist, if you will, a child and adolescent psychiatrist can call himself a scientist, that biopsychosocial formulations drive hypotheses, and then we should be gathering data to either confirm or refute those hypotheses. Constantly using the family and the treatment providers as the sources of that data in the retooling of that hypothesis that we call a diagnosis. Next slide. Transformation produces positive outcomes and broadens the definitions of success to look at multiple dimensions of what works in addition to the clinical functioning of the child. So valued outcomes include the acquisition of skills and strategies that promote success and generalize to life in the community. Continuity in important relationships, personal and institutional, leadership and empowerment skills and roles, and ultimately youth and family satisfaction. Those are our goals. Next slide. Transformation is a process that should be informed through the use of performance indicators and outcomes evaluation. So after the initial Building Bridges meeting, when we set out the joint resolution and kind of came together to decide and agree that residential treatment and community-based care should be working collaboratively, we then went on to develop some performance guidelines and an indicators matrix so that we can start measuring our outcomes. And we also developed a self-assessment tool so that providers could actually see how in concordance their practices were or were not with the Building Bridges guidelines. Next slide. We really emphasize the centrality of this child and family team, which was composed of the youth themselves, family, providers, and we wrote family very broadly, by the way. Others chosen by the youth and family from their community, their spiritual community, their neighbors, extended family, and then both before, during, and after residential, we would include the child and family team in the discussions about the needs of that child and family team and how best to meet those needs. Family and youth are involved directly in all aspects of treatment planning. Like I said, some programs are actually jointly writing treatment plans with families and youth. Family and youth have choice in selecting members of their child and family team. And family and youth have choice of providers and services whenever possible. Like I said, many families wanted to be able to have some say in which residential program the child would ultimately get placed at, and have some benchmarking metrics about length of care or philosophy of treatment or restraint statistics, whatever, that could help guide their decision making. Of course, this is in settings where there's multiple providers in one area. Next slide. Just a note about governance. At Walker, we have a parent on the board, a full member of our voting board, and it's been incredibly helpful to have that parent voice. It has to be, by our bylaws, a parent of a child who's currently in residential treatment. We also have a alumnus of our program who was in residential treatment a number of years ago, who's on our board and actually is part of the search committee for our new executive director at Walker, only the third executive director in 55 years of the organization. Next slide. So then we move to a focus on outcomes. You know, how are we going to go about operationalizing these Building Bridges Initiative joint resolution concepts? And as I mentioned, we develop performance guidelines and indicators. You'll find those indicators and guidelines on that website, Building Bridges for Youth. It was not meant to apply just to residential providers, but to both community providers and residential treatment centers. And we divided the areas into prior to referral to residential treatment, during residential treatment, and post-residential treatment. And we felt by doing that we could kind of capture the interconnectedness of the residential treatment experience with community care experience. Next slide. These are just some examples. You know, I define what a performance guideline is versus a performance indicator. Next slide. And then I gave you some small snapshots. You know, these are just several in each domain of probably more than a dozen that appeared under each heading. So an example of a performance guideline in the referral entry column, that there would be formal and informal supports and services and relationships, both existing and those identified as being needed, would be inventoried in what we call the Comprehensive Community Resource Assessment. The residential intake process is coordinated with existing care providers to reduce duplication of assessments and paperwork, etc. Next slide. And then a performance guideline example during the residential stay would include something like visits cannot be canceled or abbreviated by staff without the approval of the child and family team. Again, kind of forcing the issue that visits with family members are a right, not a privilege. So you don't have to earn them. Next slide. And then similarly, performance guidelines around post-residential. The transition plan is a component of the treatment plan, and the transition plan maximizes service and provider continuity, etc. We wanted to give measurables. We wanted to really make it clear what we were referring to and put more meat on the bones of the Building Bridges ideas. Next slide. Then I just give you some examples of performance indicators. So again, in the referral entry column, a performance indicator would include % of youth and families provided with objective quality assurance and performance data about providers to inform choice. Of course, that's not always going to be possible, but it's okay that the Building Bridges ideas were aspirational, and we all acknowledge that. Next slide. During residential performance indicators, another example, again, there's many, many more on the website. The % of emergency safety interventions that have a formal debriefing with staff, youth, and family members. That's kind of a euphemism for restraint and seclusion. Next slide. Post-residential performance indicators. We were looking at, for instance, percentage of youth and families who continue to receive planned aftercare services for 3 months post-discharge. You know, residential providers would say, well, we can't be responsible for that. So we would challenge the system, both on the res and the community-based side, how can we ensure together that that outcome, which we would all agree is important, was achieved. Next slide. So in addition to the performance indicators and performance guidelines matrix, we then developed a self-assessment tool with the idea that providers could look at themselves and see how closely aligned they are to achieving some of the outcomes that we've set through the Building Bridges initiative. It also was meant for community-based providers to complete. Next slide. So the self-assessment tool should be ideally completed by groups of staff, family members, youth, and others in the community. Not necessarily all gathered around the same table, but with the idea that it was a shared information receiving document, that you could get results from multiple people involved in the system. Both cross-functionally and cross-discipline. Responses might include steps ranging from better communication with family members regarding existing policies, to adopting new treatment approaches, to redesigning professional development activities. And I can tell you, Walker was one of the first sites that piloted that self-assessment tool, and we learned a lot about ourselves. You know, we thought we were pretty far along this path, but there's always further directions one can go. You know, and then how do you adapt it to the particular, you know, circumstances? So, you know, Walker works with pretty young children, ages 5 to 13. So how did we meaningfully imbue youth voice and youth-directed activities when we're talking about some children with who are so young? Next slide. So the next steps in terms of building bridges, you know, continuing to ensure we are effectively linking residential and, by extension, I would say inpatient treatment with community care. In Massachusetts, we were one of the first statewide initiatives to do a complete rebidding of our residential contracts using building bridges concepts. So for one thing, it's combining both our child welfare residential dollars as well as our Department of Mental Health residential dollars, and they had very different ways of contracting with service providers. They've now come together and jointly put out this procurement with building bridges concepts and some of those performance indicators embedded into the contract, which is really changing practice in a fundamental way. The bid is just about to come out, and it's driving all sorts of interesting conversations between residential and community care providers, because most residential providers are realizing they don't have within their own corporate structure all of the components that they feel they're going to need to be able to be a player in this new world of building bridges-driven rebidding contracts. So a future where the system is designed with the child and family in mind rather than the needs of the provider community. I think that's our aspiration, and it's going to be interesting to see where this all goes. The last slide is just a reminder of where you can find all the instruments that I've just been discussing. And I'll stop there and take any questions you might have.
Phone lines will now be unmuted for the Q&A portion of this event. If you choose not to ask a question, please mute your phone to reduce background noise. You may also submit a question online by clicking the Q&A icon located in the floating toolbar at the lower right corner of your screen.
So, Chris, thank you for that presentation. It was pretty comprehensive. I actually had a question that goes back to where you mentioned that some states are warrantying services. And could you say more about what states those are actually, and whether and how this has improved care, and how these states are actually measuring, for lack of a better word, failure? So when does this warranty kick in?
Yeah, and I might have misspoken a little bit. It's certainly the thing that gets people's attention right away when I talk about a warranty. It's not so much states that have been doing it. Some providers have been offering a warranty on their services, so I apologize. Damar Associates in Indiana, I believe, is one example where they will tell funding sources that if a child who they have served has transitioned back into the community, is determined to need another out-of-home placement, they will bring that child back into one of their out-of-home sites. And they do a lot of kind of residential without walls, if you will. Mm-hmm. So they're staffing kids often in community settings, sometimes in their own home, but often in a community-based home setting, almost a group home model, with residential kind of base supports. And they'll take the child back in and try to stabilize their behavior sufficiently for them to be able to transition. The decision is jointly, so it's by the whole child and family team determines whether that option is necessary and when the child is ready to be back in the community.
Thank you.
You're welcome.
Are there any other questions? Okay, well, if there are no other questions for Dr. Balanci, we're going to move on to Roy Lightstein and Brian Hancock.
Great, thanks, Diana. So Roy and I are going to talk a little bit about the experience of New Jersey as we implemented our system of care and the way in which residential services has changed as the system of care rolled out. So I think you'll see how we've tried to embody system of care principles within residential care in a way that really has worked quite well for us in New Jersey. So you can go to the next slide. So I just want to go over 4 real things here. Principles of care, so how did we arrive at the principles by which we wanted to change how we did residential care. The model we used, which was just really a community-based model for residential services, and the outcomes we accomplished, what we're seeing from those programs where we've been able to implement this model. And then Roy's going to talk a lot about the model in action, how he's actually implemented some of these programs and done quite well with them. So our principles for redesigning residential services. We started with the just the admission that we were going to need residential care. As much as everybody wants every kid to be able to be served in a home in their community with their family, we know that the reality was, at least in the short term, that we were going to need residential care. And so but we wanted to look at how we could change how we delivered residential care to make sure that it met our system principles and could be as effective as possible. And so we did that by saying that the least restrictive, most normative environment is not just for community-based care. Lots of people want to talk about least restrictive being about providing community services by providing in-home or clinic-based services. But really what we wanted to do is say, how do we bring that principle to how we do residential care as well? So we needed to ensure that we were delivering appropriate and effective care to the children and youth who were receiving residential services. But we wanted to use the best available evidence for what would be effective within those services. And so we wanted to start with the principle that we had a need for more intense services, but in a way that was less restrictive and more community-based for our kids. And when I say that, what I mean is our population, as we implemented and rolled out our system of care, the population of kids seeking residential services changed fairly dramatically, and has changed and continues to change fairly dramatically. So when we started, we had a lot of kids who were child welfare involved who didn't necessarily have significant behavioral needs, but were housed because we were operating on an old child welfare model. And as the system of care rolled out and more of those kids were receiving community services, they were staying in their homes with their families, receiving high-quality wraparound services, that less and less of them were accessing residential care, but the kids who were left had very significant needs. And they were often in specialty categories, such as kids with fire setting or sex offending or very aggressive behaviors. And so we knew that the kinds of services we needed to deliver in residential care were going to be very intense. But we also didn't want to say, therefore, they have to be in the most restrictive environment possible. So we wanted to really move our system away from large, institutional, out in the countryside residential facilities and more towards homes where kids could have real interactions with people who are not program staff, where as much as possible they could create meaningful connections to communities and retain meaningful connections to their families and significant people in their lives. So next slide. So where we sort of landed with our community-based model, and we did a lot of planning. We looked at a lot of our data, and we looked at a lot of the peer-reviewed research. And actually in our first RFP that we released for this model, we included an addendum that had all of our resources for how we documented how we arrived at this model, so that providers, when they were reviewing the RFP, could see, what was the evidence that we looked at when we were arriving at the model, and so they could have an idea for what we were looking for. So we wanted small 5-bed homes in neighborhoods and communities. We wanted to keep these programs small so they could be intense. and individualized, and that they would create opportunities for lots of community collaboration. We thought that that would be a better model for ensuring that kids had the most opportunity for success. We wanted them to be integrated into their community, so we wanted, wherever possible, for kids to attend community schools or have the linkages to community schools and community activities. And wherever possible, kids could have meaningful relationships with people who are not program staff. We really thought that was very important, that kids could feel like there was a world beyond the four walls of whatever program they happened to be in, since they weren't going to be there forever, and they needed to be able to establish those relationships for a healthy adulthood. And the significant caveat there is NIMBY. So as we've implemented this program, we now have more than 300 beds that are built on this model. We have experienced from time to time some NIMBY issues. And so we had to come up, the first time that happened, we sort of had to come up with a very clear strategy on how we would work with providers who were experiencing NIMBY issues. And that meant we brought in the Attorney General's office. We kind of created how to build good relationships with your neighbors kind of curriculum. Now, most of our providers already had experience with doing that, but we wanted to make sure that we didn't run into barriers that would make this model not successful because of neighborhood opposition. And so, by and large, we've been able to overcome opposition where it's arisen.
Brian, I
yes.
just want to interject for anyone who does not know what NIMBY stands for. It's the acronym for Not in My Backyard. It's often the neighborhood associations that are contesting residential programs in the community. So.
Right. Yeah, not in my backyard. So that's just, any type of neighborhood resistance that would tend to come up, especially when you have a community-based program where you're going to be in a neighborhood. And so, I think it's important to be aware of that and be ready for it. So we really were committed to including very significant therapeutic resources. So we have sort of a matrix of minimum service delivery for our programs that includes everything from allied therapies up to psychiatric time and how much we expect each kid to receive each month. And so we really wanted providers to be clear about what our expectation was for therapeutic resources, and to make sure that we really, that these programs were very well resourced to be able to deal with the kinds of challenges that these kids are coming into their programs with. And we have an expectation of family involvement wherever possible, wherever we can get families to be involved in treatment, we want them to be there. And so providers knew up front that our expectation was that child family team meetings would include families, and that treatment team meetings would include families, and that families would have every opportunity to come and visit with their kids and be part of the treatment process so that transition home would be effective. Next slide. So I think one of the most important things to understand about the community-based model is that there are real costs associated with it. It's not, you don't get the same economies of scale that you get in a 100-bed facility. And when you're asking for significant therapeutic resources, you have to be prepared to pay for them. So we use a market-driven, very transparent methodology for how we arrive at rates. We look at compensation surveys for each of the positions that we're asking for time from. We use, average compensation for those positions, and we use the time we're expecting from them, and we're able to arrive at really an activity-based costing methodology for arriving at a per diem rate. And so we try, I won't say that every provider agrees with what our rate is or thinks that it's adequate, but all of them know how we arrive at it. So they know what we're expecting and how we arrive at the rate that we're paying. And I will say you get what you pay for. In many instances in New Jersey, what we had in our older programs that had held over for many, many years were rates that were inadequate, and therefore programs couldn't do what you wanted them to do. And so you really do get what you pay for. You cannot create high expectations and not provide adequate resources to deliver on those expectations. Next slide, please. So some of our outcomes, and this is where I get really excited. So residential for us is really a step below specialty. That's sort of our generic residential care, not kind of specialty behavioral needs. And those tend to be older programs that are larger and built on a more institutional model, where our specialty programs are built on this 5-bed, community-based model and deal with very significant behavioral challenges. And what we've seen is these newer programs, even though they're dealing with, I would say, by and large, much more challenging kids, at least much more complex in the way of their behaviors, their length of stay is about 25% less than what we see in residential care. Next slide. So for functional improvement, now we use the child and adolescent needs and strengths for all of our kids in all of our programs, and that includes residential. And so we've looked at what's the average improvement during care for kids who are in our standard residential programs versus our specialty programs. And kids who are in specialty improve significantly more. And overall, we have very strong rates of improvement in our residential programs, but specialty is dramatically better than our residential programs. Next slide. And we like to look at how many kids left that program to go to a lower level of care or who go home, and as a percentage of all discharges from the programs. And we've seen over and over again that kids who are leaving specialty programs are much more likely to do so successfully, not being discharged to the same level of care or higher, but going either home or to a therapeutic foster placement or foster home, or someplace that's really a family-based setting where they're going to be for a long time. So we've really, I think, are very, very pleased with the outcomes we're receiving from our model. I had a clinician the other day say, you know, I'm not really in love with that model, and I said, well, you cannot agree with the model, but you can't disagree with the results, because we've really seen very strong results from what we've implemented. So now I think Roy's going to walk us through some of what he's done, and so you can, oh, I'm sorry. One more? No, that's it. Good.
Cool. Good afternoon, everybody. I'm Roy Lightston. I'm the Executive Director at the Children's Home in Burlington County. We've been around since, the card here says 1864. I promise you I wasn't around back then. And as much as possible today, I'm going to try and give you the perspective of not just my organization and what we've done, but that of the residential providers throughout the state of New Jersey. The immediate past president for the New Jersey Alliance for Children, Youth, and Families, which is the provider association in New Jersey. Next slide, please. So I'm going to be 100% honest with the folks on the call, right? So when we heard about this changing model, residential providers kind of freaked out. We basically assumed that we're going to go out of business. And at the onset of it, the fear for providers was that the idea of reducing length of stay and reducing need for out-of-home care meant that there wasn't a place for out-of-home care or residential providers in the state of New Jersey. And what we quickly realized was this was actually a kind of wonderful opportunity for us to get on the same page and be heard with regard to many of the things that concerned us in delivering our present model. And those providers that survived, succeeded, and excel right now are ones that sort of mimic evolution and what we see in nature and have learned to adapt. And so the first step that we embarked upon was really identifying, you know, again, I'm not sure that it's the same way in everybody's state, but in New Jersey, if you put 10 providers together in a room, the first thing they're going to do is complain about the same few things that they're always complaining about. And so this was a good opportunity for us to put all of those issues and concerns on the table that we talked about our current system. And just to give you a scope from the Children's Home perspective, as of Monday, we have about a dozen programs and 112 kids in residential care. That's basically what our size is. We have a special education school. We do in-home services for youth with behavioral issues and youth with developmental disabilities as well. Kind of cover the whole spectrum. So we got these providers in a room, and one of our issues is most residential services were based off of a licensing model, right? And so RTC meant that you had 16 plus kids. It was more of an institutional-like setting. The Children's Home, for all it was worth at the time, was basically a campus-based model where we had 15 kids in a program at a time. And that served as a cost-effective measure from a contracting standpoint, but we didn't love our outcomes. And we were constantly going back and forth with the state about saying, even though we've been around for 140 plus years, we're still not considered part of the community. So one of the issues everyone agreed with was that we weren't community-based. There's also a large number of kids to be served in one location. I think we can all agree that no matter which kids that we work with, for the most part, they don't wake up one day and say, please take me out of my home. I would like to go into residential care for roughly 18 months and be separated from my friends and my family. And the only thing that could make those matters worse is if we said, hey, you know what, why don't we put you with as many other kids as possible that have behavioral problems on the mental health issues that are equal to yours or greater. Those usually don't, that doesn't make for a great equation. And so reducing the number of kids we were serving at one time in one location was certainly a goal of ours. The clinical model was antiquated. Usually what happened in New Jersey was your rate was determined on when you actually got a contract with the state. So even if it was a residential treatment center, if you contracted in 1975, you were at one rate. If you were contracted in 1985, you were at a different rate, and the varying rates could have hundreds of dollars per day difference in them, which meant your clinical model varied greatly based on the sheer numbers of who you were serving and what it was that you could afford to do. And so people were sort of piecemealing together the way that they were implementing a therapeutic model. And then the contracting method left much to be desired from both the state perspective and from the provider perspective. So on the state side of things, you saw the state saying we have these legacy contracts, right? That's a term that's often put out there, these contracts that have been around for 5 years, 10 years, some of them 50 years, and if they were unhappy with what they were getting from a provider, there's sort of little they could do. And providers have a lobbying component to them. There's a lot of politicking. There are board members that are closely tied to the state and the community, and the state didn't want to appear to be the bad guy to say, hey, nonprofit who's struggling, can't generate a surplus, you're insufficient at what it is that you're providing us. On the same respect, from the provider side of things, we're constantly saying, these rates are so old, they're so stagnant, what is it that we can, you're trying to get blood from a stone. How can we change, how can we afford to change what it is that we're doing? And so embracing the system of care and this concept of system of care meant that it was an opportunity to address all of those issues that providers have had for a significant period of time. The other thing that it did was, one of the issues that providers have is kids that are very difficult to deal with, and we're going, even though we're residential treatment, there's no place for us to discharge a kid short of a short inpatient stay on a psychiatric unit of a hospital for a child that demonstrates behaviors that we couldn't manage. I mean, one of the big initiatives on the part of the state of New Jersey was to create infrastructure inside the state from a residential standpoint that services were intense enough to bring kids from out of state. No offense to anybody here, you're all from out of state, but New Jersey wants to serve its kids as close to home as possible. And so kids that previously were being sent out of state for serious concerns and issues like sex offending and fire setting had no recourse. And while we would all love to think on a basic residential model that based on all of our assessments and diagnosis and background checks of kids, that we could forecast how they're going to do and what their background is, the truth is the first week in treatment, they're meeting with a therapist, and as they develop that relationship, a month in, the child that you thought you were serving could be very different than the child that you actually are serving. And there's disclosure of events of sexual abuse, physical abuse, fire setting history. And so this gave us an opportunity to say those kids that we don't know what to do with, that we're failing with, we have an opportunity to actually work with and change. Next slide, please. So all of that, in the previous slide, you saw a picture of one of our more traditional buildings that was used on campus. And on campus now, of the 112 kids we serve, only 22 of those kids are actually served in buildings like that. Now all of our kids are in community-based homes. This is our Ryan House right here, which is a specialty bed program. that was opened up with a system of care change. And what we needed to do was to sort of change our philosophy. We embraced that here at the Children's Home, and then it was certainly embraced along the state lines, and it flows very much with regard to, oddly enough, Medicaid and the rehab option, which was sort of the state making its move to capture more federal dollars to fund the services that were taking place in the state of New Jersey. And that is to change the concept from this is who we serve to what do we need to do to serve this child and family. The Medicaid rehab option in New Jersey is a bundled rate, but basically it's a service that you're providing, not a contract per se for X number of kids. And while we still count bed days and we still bill on a per diem basis, these programs are really designed by saying, as Brian alluded to in his component of the presentation, along a matrix of how many psychiatric hours are you providing, how many group home hours are you providing, what's your child to clinician ratio, what's your direct care to child ratio. These things superseded the licensing standards that were in existence that most of us built our program model off of, and now changed our philosophy to say, what do we need to do to serve these kids? And so literally we sat down as providers and internally here and said, okay, here's a kid, this is the child's background. Don't tell me how we can't serve this child right now. Tell me what we would need to change in order to serve this kid. What do we have to do if we have these great minds that we have and these folks that are dedicated to our mission, our vision, and getting these kids home or in least restrictive settings? What do we need to put in place to make this happen? And we don't talk about money, we don't talk about, let's just say, let's design that plan. And that's really where this sort of came from. We reduced the number of youth that are served in one program, typically no more than 5. They're in single-family homes. Most programs are not locked. Children's Home's not a locked door facility. There's probably about a 50-50 split between those that are hands-on and those that are actually not locked and hands-off. And so we were able to take these kids that were being served in groups of 15, some of them in groups of 20 or 22, and they're now dropping down to groups of 5. It's much more home-like environment for the kids. They're in single-family homes. There's typically it's a 3-bedroom house, so they're sharing the room with one other child, not unlike a brother or sister might already do. There's a single room for one child, and it really did help reduce the number of kids that were being served at one time, which also, by the way, helps for your staff that are working residentially, right? So their big issue is if with 5 kids you have maybe 2 that are, squeaky wheel gets the oil in residential care, right? And out-of-home care, it's the kid that's sort of reaching crisis or that's in pre-crisis, going to crisis that gets the time and the attention. And so your staff, it's like a pressure release valve for them because they're now working with 5 kids and not 15. They're able to take one kid aside and spend more time and attention with that individual child. And because there's those increased clinical hours now your group therapy is consisting of 5 kids. There's time for individual therapy for those to take place. Case management requirements and paperwork requirements are reduced on the part of everybody once everybody gets up to speed, because I'll talk about some challenges with the implementation in a little bit. So we're drastically able to improve outcomes and reduce the number of kids we're serving at one time. From a clinical perspective, it was phenomenal for us and for the state because we were able to adopt a true clinical model and philosophy program-wide. And I highlight program-wide there for a reason, because many programs that, whether they're embarking on an evidence-based model or not, might implement a therapeutic model, but it is a component of that agency or program that embarks on that model. So I might have a clinician that is doing cognitive behavioral therapy, but it's lost in translation on the direct care staff who are spending the majority of their time with it. Or when the child's in school, the school has no idea what that treatment plan looks like or what modality is being used. I listed a couple of different models there, and we implement a few of them here at Trauma-Informed Care Pro, Sanctuary, CBT, DBT. I'm not a huge proponent to say this is one model that works phenomenally well with anybody, but my whole concept is what this enabled us to do was to be able to get everybody on the same page. And so in the specialty model, If we're using trauma-informed care in the sanctuary model, the direct care staff are trained the same way that the clinical staff are trained. They're meeting more frequently with each other. That modality follows the child into the classroom at school. So everybody is talking to the child with the same language. If there's de-escalation techniques that are supposed to be used for a particular child, that follows along the way. So whatever model is being used, you're able to move that systemically for everybody who's working with the child, which you'll see reduces the overall length of stay and our success with the kids. And this one was a big one for a change in philosophy, but we moved to a no eject, no reject philosophy, right? So basically what happens in this system is, Brian alluded to it earlier, you had a certain segment of kids that we were serving, and I would say it was as high as 40 to 50% of the kids that we were serving were really child welfare kids. Kids didn't have an issue so much as their living condition had an issue, so much as the family might have had an issue. But the child themselves didn't have behavioral or mental health concerns all that much. Well, as you move along the system of care change, and if it's working correctly, you'll see that the kids that go into out-of-home care are the kids that have the most intensive need for services. That kind of makes sense, and that's where out-of-home placement finds its home in the system of care. Along those lines, it means you have to embrace a philosophy that says you're not going to be able to kick a kid out for exhibiting the very behaviors that you accepted them for, and you're not going to be able to reject a kid because their behaviors look just like the ones that you say you're going to treat. Did that scare some providers off? Absolutely. Did that piss some providers off? Absolutely. You know what? A decade later, the bulk of us come out with our heads held up high, saying this actually helped reaffirm our commitment to the kids and the families we serve. And sort of necessity is the mother of invention. We also said, again, go back to that philosophy bullet. Okay, so we're struggling with this particular child, or outcomes say that we're doing awful with runaways. We need a new modality. What are we doing right now? It forces us to look at that. And an asterisk always is, it's a philosophy and a policy of no eject, no reject, but it's always safety first for a child. And so while we say no eject, no reject, what that means is the number of rejections we have for kids that are coming into our programs drops significantly. The number of kids that we ejected from the program dropped significantly. But we still had kids that we rejected. We still had kids that we ejected. It just forced a communication with the state to say, here's why. For example, I might accept sex offenders in a program, but I might limit the sex offender in the program to 1 in every 5 beds in a traditional specialty bed program. So I may reject a second kid coming in because that would be child number 2. Or I might have a victim of sexual abuse in a program, and thus I'm going to reject a kid that is an offender. So again, everything is about implementation here and a philosophical approach. Next slide, please. So what are the benefits? For providers, and this is another one of our houses. This is actually a psychiatric community residence, which in New Jersey, if you're going from least restrictive to most restrictive, we change that modality to least intense to most intense. And you go treatment home is least intense, then group home, then residential, then specialty, then psychiatric community residence. And this is a PCR, psychiatric community residence that you see here. New contracting methodology updates the old and the stagnant rates for service. Brian talked about the colloquial model and the idea that we understood how rate setting took place. We advocate for that. In the nonprofit world, whatever rate it is that you're getting isn't good for duration. The model stymies out after a few years because our expenses increase without us being able to establish any new revenue source. And so as your expenses increase, you need to figure something out. But these rates were sufficient and forward-thinking enough to cover us probably 5 to 10 years down the line. They also eliminated some other concerns that existed in current rates, like geographical differences. New Jersey gets a bad rap. Everybody thinks you're just flying into Newark. I promise you, we do have country out here. And you know, the real estate values in southern New Jersey vary differently, greatly than the real estate values in North Jersey. And so this new contracting methodology took all of that into consideration and helped level the playing field. It helped certainly, and no eject, no reject, you know, from the prior slide, helped from a provider perspective too. The state loved it, right, because they have all of these kids that need services, and they knew that once they were in a bed, they were going to get there. If there was an open bed, they could go there. And from a provider perspective, certainly from a leadership perspective, it stabilized your census and your ability to generate revenue and establish a budget. So we knew if kids weren't leaving as frequently, we weren't going to have as many vacancies. Fixed rate per diem beds provide a stable cash flow and budgeting modality. Prior to moving to the Medicaid rehab option, billing through Medicaid and the reform that we went through here, most of us worked on state contracts. I got paid out quarterly. Again, other states may be much better at this than New Jersey was, but if you worked on a fiscal year and your contract was supposed to be executed in July, it would not be unusual for you not to see your first payment until September. Well, that's a huge cash flow issue for a lot of organizations, both small and large. And so one of the benefits here with regard to the system was that you could bill on a daily basis. You set up your billing with Medicaid. You can get paid weekly. You can get paid bi-weekly. And so that really helped. The programs are more community-based, they're more family-friendly, and more therapeutically sound. I talked a little bit about each one of those things. When I say community-based, I mean our homes are smack dab in the community. We have neighbors to our left, we have neighbors to our right. Doesn't always work out great. We often say that children's home is the best kept secret in New Jersey. Some folks have no idea where we are. That's okay with us too. But they are right in the community. So our kids go, kids that are in the most intensive form of treatment are going to go to the movies. They're going to go to the mall. They're going to go to the park. They're going to be out in the community. And prior to the changeover to the system of care, it was really kind of like a kid went to an open bed. So whatever was available, whoever was available, that's where the kid went to. And now, not only is it based more soundly on the therapeutic need of the child, geographically, the kids are closer to home. Closer to home for us means there's more family involvement. More family involvement, more adult caregiver involvement for us means that our success rate is going to be better. It's certainly more family friendly. A family comes to a single family home. They're not coming into a locked door facility. There's not 15 other kids that are running around. It gives them a sense of more of a caring and nurturing environment for the kids. And like I said, more therapeutically sound. We're simply able to spend much more time with the kids and the families than we were before. Better outcomes for kids, families, and providers and the state. Shorter length of stay. Our average length of stay in our residential program prior to adopting this model was 16 to 18 months. We're now at the 8-month mark, where a child's actually ready to discharge out treatment-wise at right about the 6-month mark. Same thing for specialty bed programs for our kids that are coming pretty intense stuff going on with them. They're ready probably about the 8-month mark. Speaking to Chris's comment earlier, one of the things that the system needs to do and struggles to do is to change their mentality and concept of the kids that we are working with. They make significant progress getting the community-based services in their home and the wraparound services to catch up to a child that's ready to discharge out of residential is typically the thing that has them linger the longest period of time. Next slide, please. So here are some of the challenges, and one of the things that's not listed on here is one of our major challenges was the CSA, the system administrator for the state. Building that infrastructure is very important. You're going to go to a digital age with your folks, and we switched providers for our CSA in the last couple of years, and they decided they were going to turn one switch off and one switch on, and wouldn't you know it, the switch that turned on didn't work. And so we were stuck for just a little bit where We had no means to be able to bill, to generate authorization numbers for kids, no way to communicate referrals and discharges. That was a scary time. So there are definitely some technological issues that need to be worked out. Nonprofit organizations that work in residential care typically aren't used to a hospital-based billing mentality. And the way that I say that is hospitals need to get accurate insurance numbers and bill that insurance company. And that's kind of what providers have to do. When the System of Care initiative first rolled out, I remember sitting in a meeting and they said, you're not going to have to do chase and pay. That was out and out lie. You are going to have to do, providers are going to have to do a little bit of chase and pay, where you're going to have to get folks to figure out, why is this Medicaid number not working? Why can't we generate a Medicaid number? Everything in the System of Care is based off of that. The case management entities, as folks embark upon this, there can be turf wars that take place, the old child welfare system folks, the new folks that come in that are under the caveat of mental health, and however you're rolling it out in each of your states. The more time that's spent in the planning phase of establishing whose role is what, just saying that we're going to be a team doesn't necessarily translate into we're being a team. So it's very helpful to sort of establish the rules of who gets a say, who gets the ultimate say. It's always better when the state doesn't get the ultimate say. They'll admit that later on because they hate having to play tiebreaker. So if the case management entity is going to steer the mental health component, and then the child welfare piece is going to steer the family involvement component, it's just really helpful when we define those roles. Often what happens is the provider can get stuck in the middle and they're not sure who's sort of steering the ship. So for kids and families, it can mean extended stay, extended length of stay for certain youth. And like I said, as the system changes and adapts over time, more and more intense kids are coming into the programs. Providers really have learned to adapt. We've learned to adapt and adjust to that. But that being said, our more intense kids wind up staying here and lingering, and that's because there isn't necessarily a place for them to go. So while we have an 80% positive discharge ratio here, I can't tell you the number of kids where family is the targeted place for discharge, and 3 months into treatment, family says, by the way, we're not a viable option. We don't really care what kind of progress you make. And then you have this child that has, I think as Chris said, blazed some pretty horrific path, and they wind up lingering for a couple of months as the state tries to figure out where can we place this child as they're aging out, or as they're 17 years of age. One of the things that you'll also see is that because services are based on intensity of the therapeutic intervention, less restrictive settings can be unappealing for kids to go to because they might feel more restricted even though they're not as clinically intense. And so all those words translate into, I got a kid in a single family home, they're ready to leave in 6 months on the specialty bed side of things or the psychiatric community resident side of things, and then they're supposed to go to a group home that's a locked door model with 12 other kids. Well, it's not, even though that is more cost effective for the state, even though there's less clinical stuff going on in that group home, to that child and to that case management entity, it feels more restrictive than what was going on in a higher level of care. Educational placements can be difficult. Not all of these kids have an IEP or are classified. In New Jersey in particular, you have folks that are trying to limit the number of kids that can be served in special education. They want them served in their home school districts. Schools trying to maintain kids with these behaviors can have, and histories can have a real difficult time. And Brian mentioned NIMBY issues. We lived through those NIMBY issues. It works. New Jersey is very fortunate that we have statewide legislation that says that no municipality can discriminate or pass legislation that would restrict or prohibit the placement of a group home. We're not required to do a public notification. It's a single family residence. And so for anybody who's a football fan, you can sort of be like the Baltimore Colts and leave in the middle of the night. You can just buy a home and move your program in. I have to tell you, There haven't been a tremendous number of NIMBY issues. What has been very supportive and helpful is that the state's on the same page as providers. We sort of have a mentality and a methodology of what homes make sense and what homes don't make sense, and the state needs to approve the location of the home prior to the purchase of that home. Short of that, what most providers do is they hold a town hall meeting. You know, we get to meet who our new neighbors are. Children's Home has had good experience with that and poor experience with that. You know, I'm opening a home up on Monday, and I got a doctor that lives behind us who desperately wants to buy the house from us. That's not going to happen. That being said, one of the homes you saw earlier, Ryan House, you know, this October, our neighbors dropped off a basket of candy for our girls, our specialty bag girls, dropped off a basket of candy for them and a card, you know, saying that they were happy that we were next door. We try and do things like plow our neighbors' driveways for them. Around Thanksgiving time, we have been known to drop off a couple of apple pies and some turkey here and there to maintain good relationships inside the community. I think that about covers it for us.
Phone lines will now be unmuted for the Q&A portion of this event. If you choose not to ask a question, please mute your phone to reduce background noise. You may also submit a question online by clicking the Q&A icon located in the floating toolbar at the lower right corner of your screen.
Roy, I have a question for you. It's Diana. You mentioned in your challenges conversation about the CSA, which is a system they call, I guess it's the ASO, technically. In New Jersey, they call it the CSA for the state, that changed 2 years ago or 3 years ago at this point. I want to thank our presenters today, Chris Balanci, Brian Hancock, and Roy Lightstein. I want to thank everybody who participated as attendees. I want to remind people that slides and a video archive will be available on our website shortly, and an email announcing the posting of the materials will be sent to today's participants as well. I also want to ask that you complete the very brief online evaluation, which will pop up on your screen after this event is finished. Your feedback is very important to us. Thank you again, everyone, and have a great afternoon.
Thanks, Diana.